The SIT.
This IT, is there any problem? Who is helping in the IT, please?
In the 1970s, a trial was done on the SIT, and it failed due to public awareness issues. There was negative publicity in the community, hence there was low acceptance of the technique in India. Next slide. Now, we found it important to understand the community perceptions with regards to malaria transmission and control interventions to enable us to effectively have communication messages that are suitable to the relevant community of KZN. The next slide, please. The objectives included to measure the knowledge, assess the attitudes and practices on malaria transmission, the signs and symptoms, including control measures, and also to determine the level of awareness with regards to the SIT. Next slide. The endemic provinces in South Africa is the Mpumalanga, Limpopo, and KwaZulu-Natal. And this study was conducted in the KwaZulu-Natal province, in Mamfene area, in the Jozini local municipality, in the 3 sections, section 2, 8, and 9. And these sections are currently used by the Malaria Control Program and Sentinel sites for the entomology surveillance. Next slide. This was a cross-sectional household survey, and 400 households were randomly selected. The sample size was divided proportionally according to the population size in the 3 sections. Trained field workers conducted the interviews. 1 adult per household was interviewed, and they were supposed to be above the age. Was translated into the local. Percent of the participants have had prior learning, and majority of the participants were unemployed, and there's been 12% of family history of malaria in the previous year reported. Next slide. Findings on the knowledge on transmission of malaria and SIT. We found that of the 400 participants, 397 have heard about malaria before, and they've correctly associated it with mosquito bite. 254 were able to identify at least 3 or 4 of the signs and symptoms, which included headache, fever, feeling cold, and vomiting. And 238 reported that they needed more information on malaria, with 128 correctly associating the female mosquito as the vector, and only 36% have heard about the SIT before. Next slide. And then the most commonly identified sources of malaria information in Mamfene were the local health facilities, the radio, school, and community meetings. Next slide. With regards to attitudes on malaria and SIT, of the 400, we found that 395 reported that it was important to have their homes sprayed on an annual basis, and 382 reported that malaria was prevented, with 305 having confidence in the IRS technique, and also 254 were in support of the SIT project, with only 212 reporting that malaria is still a problem in the area. Next slide. And then on practices we found that out of the 400, 396 will seek treatment at a healthcare facilities if they were to experience any of the signs and symptoms, with 254 doing so within 24 hours. 262 have their households sprayed in 2014, and those that didn't spray reported that they were not aware of the schedule and they were not at their homes during the time of spraying. In the 197 reported to currently be using the protective items against malaria, with only 9 of the participants reporting to have bed nets. Next slide. We stratify the opinion of SIT amongst the participants according to age, category, and family position. And we found that the ages between 18 and 50 are more in support of the technique as compared to the other age group. And the family position, we found that the children, as compared to the heads, are also more in support of the technique. Next slide. Then on our discussion, acceptable knowledge, encouraging attitude, and suitable practices were demonstrated by the participants. The participants were able to identify the cause of the disease and also the signs. And good acceptability of the IRS was demonstrated, with more than half of the participants having sprayed their homes in the previous year. And at least a quarter of their participants were aware that the female mosquito is a vector. And the knowledge on the SIT was low. However, majority of the participants are in support of the technique, and also healthcare facilities are being utilized for seeking information in the area. Next slide. And based on our findings, we recommended that IRS schedules need to be communicated to the community so that compliance will be improved. And the SIT awareness campaign should be designed utilizing the currently available communication platforms, so we can have talks held at community meetings, have presentation at healthcare workers, also have some radio messaging created. Training of health promoters is also recommended to include SIT on their awareness, on their health awareness activities in KwaZulu-Natal. I would like to acknowledge these people. Thank you.
Thank you very much, Pinky. Pinky is wearing pink. Sorry for the technical hitches. We will want to take the presentation by Hamadou Seko from Burkina Faso. Impact of seasonal malaria chemoprevention on malaria incidents in rural district of Burkina Faso, 2003-2015. Hamadou, you will be asking them to change the slides for you?
Yes.
Okay, thank you.
Merci, Monsieur le Président. Bonjour, Mesdames et Messieurs. Nous sommes Dr Seogo Amadou, fellow du programme Ouest africain de formation en épidémiologie de terrain. Nous avons l'honneur de vous présenter ce matin notre étude instituée Impact de la chimioprévention du paludisme saisonnier dans le district sanitaire de Waiguia, de Séguénéga, au Burkina Faso, de 2013 à 2015. Next. Nous suivrons le plan suivant. Next. Le paludisme reste la principale cause de morbidité et de morbidité chez les enfants de moins de 5 ans. La chimioprophylaxie, la chimioprévention du paludisme saisonnier est recommandée par l'OMS depuis 2012 comme une des interventions efficaces pour la prévention du paludisme. Elle peut potentiellement prévenir 75% des cas de palu. Elle consiste en une administration de 3 doses de sulfadoxine pyrimétamine plus de l'amodiaquine durant la période de haute transmission du paludisme. Next. Au Burkina Faso, la stratégie est mise en œuvre depuis 2014 dans 7 districts sanitaires, dont le district de Séguénéga. Les données de la chimioprévention du paludisme saisonnier sont disponibles, mais aucune analyse n'est faite. Il y avait aussi un besoin de perception de l'impact de cette nouvelle stratégie par le programme national de lutte contre le paludisme. C'est pourquoi nous avons voulu, à travers cette étude, décrire l'évolution de l'incidence du paludisme dans un district d'intervention, le district de Séguénéga, en comparaison avec un district sans intervention, et nous avons choisi le district de Titao, et de mesurer l'impact de la CPS dans le district de Séguénéga dans la lutte contre le paludisme. Le Burkina Faso est un pays de l'Afrique de l'Ouest avec une superficie de 274 000 km² et une population d'environ 19 millions. Il compte 13 régions et 17 districts sanitaires. Pour notre étude, nous avons considéré 2 districts. Un district de mise en œuvre de la stratégie et un district ne mettant pas en œuvre la stratégie. Pour le district de mise en œuvre de la stratégie, nous avons choisi le district de Séguénéga, qui avait été identifié du fait de l'incidence élevée du paludisme qui y prévalait. Le district qui ne met pas en œuvre la stratégie, nous avons choisi le district de Titao, du fait qu'il est voisin du district de Séguénéga et qu'il présente les mêmes réalités géographiques, environnementales et socio-culturelles que le district de Séguénéga. Une particularité à considérer est la mise en œuvre de l'exemption de paiement des soins dans le district de Séguénéga depuis 2012. Au Burkina Faso, un cas de paludisme se définit comme une personne ayant une fièvre ou un antécédent de corps chaud dans les 72 heures et la mise en évidence du plasmodium à l'examen microscopique ou à la positivité du test de diagnostic rapide du palud. Nous avons mené une étude descriptive basée sur une analyse de données secondaires du paludisme des enfants de 0 à 59 mois dans les 2 districts. Nous avons extrait les données de la base District Health Information Software et nous avons utilisé Epidemiology pour l'analyse de nos données. Nous avons calculé des proportions, des fréquences et des incidences. Diapo. Mesdames et messieurs, quels sont nos résultats? Cette figure est une courbe qui présente l'évolution de l'incidence du paludisme chez les enfants de moins de 5 ans dans le district de Séguénéga, de 2013 à 2015. La lecture de cette courbe, avec les périodes de mise en œuvre de la chimioprévention du paludisme saisonnier, permet d'observer une diminution progressive de l'incidence du paludisme de 2013 à 2015 dans le district de Séguénéga. Diapo. En effet, sur ce graphique qui présente 2 courbes décrivant l'évolution de l'incidence du paludisme par mois chez les enfants de moins de 5 ans dans le district de Séguénéga, district où on met en œuvre la stratégie, courbe en vert, et le district de Titao, courbe en violet, où la CPS n'est pas mise en œuvre, nous pouvons observer. Dans le district de Séguénéga, quoiqu'il y a une incidence du paludisme élevée, présente une diminution progressive. Pendant que dans le district de Titao, cette incidence est progressivement croissante pour la même période. Diapo. Ceci est objectivé par ce graphique qui montre globalement les dites tendances, à savoir une réduction de l'incident du paludisme de 46% dans le district de mise en œuvre de l'intervention et une augmentation de l'incidence de 21% dans le district de Titao, district qui ne met pas en œuvre la stratégie. Diapo. En discussion, nous disons, dans notre étude, nous avons noté une réduction des incidences dans le district sanitaire de Séguénéga de 46%. Selon l'OMS, la mise en œuvre de l'intervention peut réduire l'incidence du paludisme de 75%. Koskalova, en 2013, a retrouvé une réduction dans une étude multicentrique menée en Afrique de l'Ouest de 83%. L'ERIS, en 2012, quant à elle, a retrouvé dans des sites pilotes au Tchad et au Niger une réduction de 65%. Diapo. La réduction relativement faible de l'incidence notée dans notre étude pourrait s'expliquer par le fait d'une surestimation du numérateur, du fait de l'exemption de soins dans le district sanitaire de Séguénéga qui attire les enfants des districts voisins, de la non-exclusion des enfants de moins de 3 mois, enfants non éligibles par la chimioprévention du paludisme saisonnier dans la collecte de données et du fait que la 2e et la 3e dose ne sont pas supervisées par un acteur de santé, médicaments remis à la mère pour les 2 jours. En somme, nous avons noté une réduction de l'incident dans le district de Séguénéga, une persistance de l'augmentation de l'incidence du paludisme dans le district de Titao. Ainsi, nous pouvons dire que la chimioprévention du paludisme saisonnier a contribué à cette réduction. Pour cela, nous recommandons au programme national de lutte contre le palu d'étendre la chimioprévention du paludisme saisonnier au district de Titao et partant à tous les districts du Burkina, d'initier une étude approfondie pour évaluer l'impact réel de la chimioprévention du paludisme saisonnier dans le contexte du Burkina Faso. Diapo. Comme action de santé publique, nous avons partagé nos résultats avec le programme national de lutte contre le palu au Burkina Faso. La chimioprévention du paludisme saisonnier a été étendue au district sanitaire de Titao en 2016 après une présentation de notre analyse à une rencontre réunissant les autorités administratives et sanitaires. Nous voulons terminer en remerciant les organismes et institutions suivants qui nous ont supportés dans la réalisation de notre étude. Nous vous remercions. Merci.
Thank you very much, Amadou.
Yes.
We are very sorry for the technical issues that happened in the last presentation. Because of the time constraint, we may not allow any time for questioning. But you will have to, no questions. You may have to meet the presenters after the session. They are all going to be around if you have any burning things that you want to clarify from them. But today there will be opening ceremony, and we must really work towards getting our timings right. I want to thank you for your cooperation throughout the session. Me, Professor Sabitu, and my colleague,
Tim Doyle, yes.
Yes, that chaired the session, are very, very happy for your cooperation. Before we leave this seat, I will want to ask the moderators of the next sessions to come forward. They are Professor Fawole and Dr. Ambrose Talisuna. Please come up to the podium and you will introduce your presenters. Thank you very much.
Thank you very much. We're running 15 minutes late, and my name is Ambrose Talisuna, not Talisman, but maybe I should become a talisman. This is a very interesting session, and we are following on from the morning one on malaria. And I would have given some kind of introductory remarks, but given the time constraints, I would like us to just introduce the next presenter, who is going to talk about the U.S. government's malaria control efforts in sub-Saharan Africa. And Dr. Richard Niska. Is Dr. Richard Niska around? All right, so our presenter today, Richard, is quite distinguished. Richard received his doctorate in medicine from the University of Virginia and his master's of public health degree in epidemiology, biostatistics, and tropical health from the Uniformed Services University of Bethesda in Maryland. He's board certified in emergency and family medicine. He's currently with the U.S. Centers for Disease Control and Prevention in Abuja, Nigeria, where he serves as the resident advisor for the President's Malaria Initiative. He has extensive international experience, including assignments to Botswana, Nigeria, Central America, Haiti, Iraq, Micronesia, and Tanzania. He is on the preventive medicine adjunct faculty at the Informed Services University and the public health policy adjunct faculty, George Mason University in Arlington, Virginia. Please welcome Richard.
Okay, thank you very much. Okay, welcome to the session and bienvenue for the Francophone. I'm here today to talk about the U.S. government malaria control efforts in sub-Saharan Africa in general, and I'm honored to be able to present at this international conference. I appreciate that. My name is Richard Niska. I'm a medical doctor. I'm the CDC resident advisor for the President's Malaria Initiative here in Nigeria, based in Abuja. Next slide, please. First, I'd like to just give a short introduction to malaria itself. It's caused by a parasite. The genus is Plasmodium, and there are 5 different species that infect one to give you malaria. Plasmodium falciparum is by far and away the most common, both in Nigeria and the rest of Africa. And there are 4 other species. Here in Nigeria, we tend to have more of the malariae than the others, such as Vivax ovale and Knowlesii. But falciparum, again, is the most common. The mechanism is that the parasites invade the liver first and develop there. The Plasmodium falciparum emerges into the bloodstream in about a week. Other species may emerge weeks later. The parasites then invade red blood cells and multiply. They rupture the red blood cells, and this causes obstruction of blood vessels, leading to some of these syndromes, such as cerebral malaria. Next slide, please. Next slide, please. Okay, some symptoms well known to all of you. Symptoms of falciparum malaria are usually within 7 to 30 days. High fevers are the main symptom, and indeed the symptom that's most commonly reported by people coming to clinic. You may have shaking chills in the classic sense, but oftentimes just a simple high fever. The other symptoms, like many tropical diseases, are nonspecific, as a flu-like illness, headache, muscle aches, vomiting, abdominal pain, which could describe a lot of illnesses besides malaria. Malaria does cause severe illness and death, although with partial immunity, one can have a fairly benign syndrome and get it multiple times. The symptoms of Vivax malaria can rarely take up to a year to develop, and it's thought to be a relapse for which the initial blood stage may have been suppressed. There's delayed emergence from the liver, which is an unusual exception. But because of this delayed presentation, the healthcare provider, especially if you're going outside of Africa, should be made aware of the travel history so that they know to consider that in the differential diagnosis. Okay, how is malaria transmitted? By mosquito bites, Anopheles species transmits the malaria. The mosquitoes pick up the parasites from infected people. The parasites develop within the mosquito a stage called sporozoites. The parasites are then passed on to other people through the mosquito bite. Generally, the mosquitoes that transmit malaria, the Anopheles, bite at night, which leads to the major intervention using bed nets for prevention of malaria because they are biting at night. If you're interested in noting how the behavior of Anopheles mosquito, if you let it land on you and see how it's sitting, generally the Anopheles mosquitoes will put their abdomens in the air at an angle as opposed to some of the other mosquitoes transmitting other diseases that rest more parallel to the ground. So that's one way to tell the Anopheles. Next. Okay, how to protect yourselves and your family. Anti-malarial prophylaxis, not so much an issue in Africa where people have been exposed to that malaria since infancy. But if you do leave Africa for more than a few weeks, you may lose some of the immunity that you developed over the years, and you may have to consider, especially if you're back and forth between Africa and, say, Europe or the United States, you may have to consider being on malaria prophylaxis. The medication choices vary with the area of the world, and it's good to consult the healthcare provider before traveling. Insect repellents are important if you have access to them. Long sleeve shirts, pants, and socks in the evening outside, just protecting yourself, especially if you're sitting out in the evening. It would be good to just wear long sleeves and pants, socks, long dress, whatever, socks and shoes in the evening outside. And although I list this last, the main intervention for protection within Africa is the insecticide-treated nets. Next slide, please. Okay, the overall status of malaria in Africa. Africa is most affected due to a very efficient mosquito vector. Anopheles gambiae is the predominant one here in Nigeria, although I know from the previous presentations that other species may transmit in other areas of Africa. The predominant species is Plasmodium falciparum, which is the one that's most likely to cause severe malaria and death, as opposed to the other 4 species. Local weather often allows transmission to occur year-round, although within Nigeria we have different ecological zones where the transmission can be seasonal, especially in the north. But in the central area that we find ourselves here in Abuja and in the south, the transmission is year-round. And scarce resources and socioeconomic instability hinder control activities throughout Africa. Nigeria does report more malaria deaths than any other country, and I have a reference at the bottom there. The most vulnerable are persons with little or no immunity. In sub-Saharan Africa, the most vulnerable are the young children who haven't yet developed the partial immunity